welcome to this podcast on why does the use of microcatheter bring you benefits. I'm introducing myself. I'm Roberto Garbo, interventional cardiologist from Turin, Italy. And I think that this is a very important topic because many operators think that microcatheter are useful only in CTO PCI. I don't think so. I think that microcatheter are really useful also in complex coronary intervention, and CTO operator can be a better operator why is able to use CTO tools like microcatheter and guide wire only in complex PCI. It's a great honor for me to have Professor Carlo Di Mario, a great expert interventional cardiologist and president of EuroCTO Club, is in Florence, Italy, and he will talk about the use of microcatheters. So I want to hear about him if he has the same thinking that. So please, Carlo, go on.
I fully agree, Roberto. I believe that in general, doing CTO is a way to learn how to do complex interventions in general. It's true, microcatheters have been developed mainly for CTO recanalization, but they are useful in many other situations. Look at these slides where I try to summarize the different applications. For the same reason why you like to use one wire in part of the procedure and then exchange your wire, you definitely would prefer to have a microcatheter for a very tortuous vessel, maybe calcified, where a very slippery, lubricious wire can go through, but then once you have crossed the tortuous segment, you will prefer to go back to your classical workhorse wire, giving more support with less chance of distal perforation. In general, wire exchange is an important reason to prefer a microcatheter. Think of the Rota wire. They now claim from Boston Scientific that their new wire is great. Well, I still have to test it, but I confess I heard it many times, and in general, I would prefer to wire even relatively simple lesions with a normal wire and then exchange over a microcatheter for the Rota wire. It's also important for distal injection to have a microcatheter. This is not only in the context of CTO to see septal collaterals to make sure you are in the distal lumen of the vessel, but also it's important when you want to distinguish between no reflow and the presence of a dissection. You don't see the distal vessel, but the way you treat this situation is completely different in the two scenarios, and just advancing a microcatheter and injecting distal, you have a solution. And part of the solution, if it's no reflow, can come again from a microcatheter. You use adenosine, you use nitroprusside, drugs that have very severe hemodynamic effects if you inject in the aorta, but are extremely well tolerated and extremely efficient when they are injecting distal. And all what you need is again a microcatheter. You can use a microcatheter also to deploy coils, fat, thrombin, whatever method you are used to close perforations. And of course, these are normal devices used, for instance, by neuroradiologists for treatment of aneurysm. Retrieving gel material, you advance the microcatheter as much as possible, and then you exert all your traction in the last portion of the wire, and this would normally facilitate retrieval of the entire wire. I think there are some more specialized application of microcatheters in the context of bifurcation, but we will see them in a different podcast. Let me briefly tell you which type of microcatheter we have. And you see in the next slides listed a series of them. I couldn't show them all because there are too many, but let's see the difference between the first three, but there are now equally well performing extremely thin microcatheter that can go through a very severe occlusive or subocclusive stenosis. These microcatheters cannot be steered inside the lesion. That's the only difference with the microcatheter that you see listed from 4 downwards. They are more specialized microcatheters that you used for retrograde recanalization or anterograde recanalization of CTO, and we will discuss them again separately.
So thank you, Carlo, for your clear presentation. So talking about a case example, can you share us a case example of microcatheter used outside CTO fields?
Yes, Roberto, I think you are right. Showing a case sometimes is better than 1,000 talks. And I've not chosen the most difficult, the most demanding case. And again, will not be a CTO. He's an 82 years old gentleman who had an anterior myocardial infarction more than 25 years ago, received a bare metal stent for that, and now he has ischemia in the same territory. You see in the next slide from the baseline angiogram that the right coronary artery has no significant lesion. You notice the presence of calcified stenosis in a large proximal left circumflex, but only in the following slides, in left caudal, in right caudal and left cranial view, you see better the LAD and the extent of tortuosity, of severity, of diffuse disease present in the proximal and mid segment, partially within the previously deployed stents. Of course, you may try a simple wire and you may be successful. Personally, when we have these and complex tortuous calcified lesions, sometimes also in the context of an acute occlusion of an ST elevation myocardial infarction, I will have a very low threshold to use a microcatheter. In this case, you see, I've already crossed with an XTR wire, and the Navision microcatheter follows extremely well distal. At this point, I can withdraw, confirm by intracoronary injection if I need my position, and then exchange for my workhorse wire, and then perform the rest of the procedure that I will briefly summarize with pre-dilatation. And in the next slides, you see that already a first stent is implanted. It looks a reasonable result after a stent implantation in the mid and proximal segment, but we left untreated the very proximal stent, and we checked with OCT, as you can see, the situation, which still shows severe dissection within the previous stent. So we decided to treat proximal LAD, left main and circumflex, implanting a stent in the circ, crushing the stent with a balloon in the main vessel. And at that point, we perform a real double kissing crush technique, including 2 pots to achieve the results that you see in this final slide, including the OCT showing excellent apposition after this demanding, but in my view, best technique for treatment of bifurcation. We may have used, if needed, the microcatheter again, if we had no reflow during the procedure, if we had difficulties to cross with the balloon after having jailed the side branch. We didn't need in this case, but a microcatheter on your side is always a friend.
Carlo, we know that the monorail technique has been invented to avoid laborious wire exchanges with 3 meters long wire. So we need to go back with this cumbersome method to retrieve our microcatheter. We know that this can be a problem for many operators. So the way how to remove microcatheter in the coronary artery once we need to put a balloon or stent to conclude our procedure. So which are the other methods we can use in this situation?
Well, very good question. I think that the main reason why people don't use microcatheters is that they are used to only one way to perform procedure, monorail. This has been introduced by Tassilo Bonzer while you were still in high school, probably Roberto, but believe me, I used the over-the-wire technique. It was much more cumbersome. Using 3 meters of wire is definitely not ideal for all cases, but you don't need it. First of all, because all wires can be extended. Name a brand, Abbott, Terumo, Asahi, whatever, they have extensions, so you can just to connect them if you need it. And this might be required only when you have super small guiding catheter, for instance, 5 French. In all other cases, you can use trapping. You can also use, even with the 5 French, this hydraulic method that you see on the right side of the screen, and it's simple to describe. You just put the microcatheter as far back as possible, then you connect it to the indeflator without air in the indeflator. You make sure the wire is not trapped while you do that, and then you start to increase pressure in the indeflator while you pull back the microcatheter in the indeflator assembly. The wire will magically remain in place because you exert strength through the pressure given by the indeflator, while all the rest will come out. Make sure that you don't touch and desterilize the microcatheter. You may need it again. This is one way, but I will not recommend that, especially if you spend 1 hour to cross a complex occlusion. Normally, the way you will do is trapping, and this is shown in the cartoon on the left side of the screen. And what you can see is that you have only to withdraw your microcatheter within the guiding catheter, advance a second balloon as far as it goes within the microcatheter. Don't come out, because otherwise you may slide it inside the vessel without a wire, very dangerous. Inflate your balloon. This will block the wire while you withdraw the microcatheter. The only point requiring attention is the fact that you may have air within the guiding catheter. So once you have deflated your trapping balloon and removed it, make sure that you see bleeding from the Y connector, including the side port of the Y connector. With this attention, we always get a good result. But in the next slides, you see that now there are different dedicated devices for trapping that makes use of microcatheters extremely easy. So, of course, normally you will use semi-compliant monorail balloons. Use a 2O balloon for a 6 French guiding catheter, beta 2530 for a 7-8 French, go to 14, 16 atmospheres, and then you will perform the trapping the way I described before. Remember, that balloon will be damaged while you do that, because without a wire inside, the lumen will collapse. It will be very difficult to reuse it. But again, you can use dedicated system. There are now 2 different balloons. One is called Trap It from IMDS. The other is called Trapper from Boston Scientific. The only advantage, to be honest, is that you cannot make a mistake and go outside the guiding catheter. They always come in different lengths according to the fact that the guiding catheter is normal, 100 centimeter long, or shorter, for instance, 90 centimeter long. But what I tend to prefer and use most, when I need a guide extension, which is often the case for CT organization, you like to have this additional support. Instead of using a normal one, use the trap liner, which has a balloon at the proximal end of the extension. And once you have withdrawn the microcatheter more proximal than this balloon that is possible almost always, except in extremely distal occlusions. And if you have wires that are shorter than 200, 210, like the normal new wires for CTO tend to be, but 95% of the times that will be possible. Then you inflate the balloon, withdraw your microcatheter, have the same attention for the air, and that's the final outcome is achieved. You have your wire ready to insert new balloons, new stent, and complete the procedure. So this is the only difficulty that you potentially have in microcatheters. Make sure to follow this easy step and you will succeed.
So thank you, Carlo, for this clear podcast, clear presentation. We understood that we have the microcatheter have many more application that are not only CTO PCI, but even in many situations of complex PCI, they can help us. And you explain with your case example how it can be easy with the trapping balloon technique to retrieve microcatheter for changing our procedure in a regular PCI with balloon and stent. So thank you very much for that. And it was a pleasure having this podcast with you. Thank you for iVascular for that make possible this.
Let me finish by thanking iVascular for the support giving for this podcast and in general for all the initiative of the EuroCTO Club.